Dr. Yasser.
Yes, Dr. Sir.
Okay. Good, but can I ask you just to mute the mics for the all candidate to prevent the echo, please? Dr. Mubashir. Okay, thank you. Okay, Dr. Ashraf. Mr. Hassan is 35 years old. Station 2 history taking. Mr. Hassan is 35 years old. He has been complaining of recurrent attacks of headache and sweating for the last 3 months. For your kind care. Until Dr. Yasser to prepare the case, we have Dr. Faid. This is the first time to attend our discussions, just to give brief how to prepare to station history taking. He will give you the scenario before going to the exam, and you have to read the scenario in proper way. Then you have to write in a white paper the differential diagnosis of the complaint. What's your differential diagnosis? Then you will ask the surrogate about the analysis of the complaint. Then your differential diagnosis, symptoms of differential diagnosis, then the other systemic review in details, including social history, medical history, family history, and drug list. Then to do summary of the positive data of the scenario, then to ask about the concern, then to reply the surrogate.
معلش السيناريو تاني دكتور صادق.
Yes, Mr. Hassan is 35 years old. He has been complaining of recurrent attacks of headache and sweating for the last 3 months.
Can we start, Dr. Sadiq?
Okay, Dr. Ashraf.
Good evening, Mr. Hassan.
Good evening, Doctor.
I am Dr. Yasser, Senior House Officer in Medical Clinic today. Happy to see you.
Nice to see you, Doctor.
Yeah, Mr. Hassan, first of all, I want to confirm this information. You are 35 and complaining of recurrent headache and sweating over the last 3 months. Is it okay?
Yes, Doctor.
Mr. Hassan, I will write some notes. It will be confidential, and I will full concentrate with you. Is it okay with you?
Yes, Doctor.
Can you tell me more about your condition, please?
Yes, Doctor. Since for the last 3 months, I have been complaining of recurrent attacks of headache and sweating coming on and off.
Yeah. Before these 3 months, you are completely okay?
Yes, Doctor.
Yeah. Can you tell me more about the headache? Where is the site of the headache?
It is all over my head, Doctor.
Yeah. What is the type of this headache?
It is dull ache headache, Doctor.
Yeah. What exacerbates this headache?
I'm not sure, Doctor.
About the course of this headache, it is nowadays deteriorated, progressed more than before?
Yes, Doctor.
Yeah. It is relieved by any medication, by any rest?
No, actually, Doctor. I tried ibuprofen that my GP prescribed for me, but it doesn't work.
Sorry, Mr. Hassan, for this. If we score this headache from this pain from 0 to 10, how much you will give?
Maybe 8 or 9, Doctor.
Sorry for this. You have any problems in your eyes,
No, doctor.
in your teeth, in your nose?
No.
Yeah. Also, there is sweating with this pain. This sweating at the same time with the headache?
Yes, doctor.
Yes. So I want to ask if you have any tummy pain,
No, doctor.
you have any altered bowel habits,
No.
you have any loose motion.
No.
What about your water work?
Yes. Oh, it's okay, doctor.
No change in your water work, in color, in quantity.
No.
Can you tell me you have any chest pain,
No, doctor.
any heart awareness?
Yes, sometimes, doctor.
Is it regular or irregular?
No, it is regular, doctor.
You have any shortness of breathing?
No.
You have any cough?
No.
What about if you are lying down, there is any shortness of breathing?
No.
There is any ankle swelling?
No.
You have any cough or coughing of blood?
No.
Can you tell me you have any weakness in your body?
No, doctor.
Any abnormal sensation?
No.
Any difficulty in speech?
No.
You check your blood pressure, Mr. Hassan?
No, doctor.
So, Mr. Hassan, how frequent this headache and sweating nowadays?
You know, doctor, when it started, it was maybe 2 to 3 times per day. Now it is more frequent, and it comes to me maybe 5 to 6 times per day and more severe.
Sorry for this, Mr. Hassan. How much it lasts? How long it lasts?
Maybe for 1 hour, doctor.
1 hour. How it's how it's going spontaneously or been by or any?
No, fade away spontaneously, doctor.
Yeah. Not exacerbated by any type of food, any medication.
No.
You have any weight loss?
Yes, doctor. I have weight loss 3 kilograms for the last 3 months.
So, what about your appetite?
It's okay, doctor.
This is intentional weight loss?
No, doctor. I didn't intend to lose my weight.
What about your diet?
It's okay, doctor.
Exercise, the same exercise as before?
No, actually, I have no time for exercise. You know, I'm working most of the time, so no time for exercise.
Yeah. Can you tell me you have any shaking in your shaking movement in your hands?
Yes, sometimes, doctor.
Yeah. You have intolerance to hot to cold?
I'm not sure about that, doctor.
You feel anxious, easily anxious?
Because of my racing of heartbeats and this sweating, I feel anxious sometimes because, you know, the symptoms are very strange for me, doctor.
Sorry for this. You have any flushing in your face with this headache and this sweating?
No.
You have any rash, skin rash?
No.
You have any joint pain?
No.
You have increase in your pallor than before?
No, doctor, I didn't observe that.
Sorry to ask you again, you have any double vision?
No.
Any proptosis in your eyes?
What do you mean by proptosis, doctor?
Any bulging in your eyes?
No.
Any change in your hair?
No.
Any yellow discoloration of your eyes?
No.
Any pigmentation, especially in your mouth?
No.
Can you tell me you have any medical problems, Mr. Hassan?
I have high blood pressure.
Since how long?
It's for the last 6 months, doctor.
Yeah. What do you take for this blood pressure?
I'm taking what's called lisinopril, doctor.
Is this controlled with this medication?
Actually, my GP said to me it is not controlled because my last blood pressure was 145/90.
Yeah. You are compliant with medication?
Yes, doctor.
You have any allergy of this medication or any side effects from this medication?
No.
Other than this high blood pressure, you have any other medical problems?
No, doctor.
Can you tell me about your drug list? Other than this lisinopril, you take any regular medication?
No regular medication, just maybe ibuprofen when I have this headache, doctor.
Yes. You have any family history of similar problems?
No, doctor.
Or any family history of chronic illness like diabetes, high blood sugar, high blood pressure also?
I'm not sure, doctor, because my dad died when he was 35 years old.
Sorry for this. Can you tell me what is the cause of his death?
Yes, he told me that he died because of cancer of his kidneys.
Sorry for this. Sorry for this. I want to ask about your job.
Yes, doctor.
What's your job?
I'm a swimming teacher, doctor.
Sorry, again?
A swimming teacher.
Yeah. How it affect your work?
It affects so much, doctor. I cannot cope with that.
Sorry for this. Sorry for this. I can contact social worker to help you on this issue. It is okay with you?
Yes, thank you, doctor, for that.
Yeah. I also will try to reach diagnose and give those a proper treatment. Can you tell me with whom you are living?
With my wife, and I have one kid.
Yeah. They are supporting you?
Yes, they are okay.
Yeah. They are healthy.
Yes.
Do you smoke, Mr. Hassan?
No.
Do you drink alcohol?
No.
What about your mood, Mr. Hassan?
I have bad mood because of this recurrent headache and sweating, doctor.
Sorry for this. But still life is precious for you?
Yes.
Yeah. What about your sleep?
It's okay, doctor.
Can I ask you some private question?
Yes.
You travel abroad recently?
No.
You have about your sexual, you have any extramarital relationship?
No, doctor.
Mr. Hassan, can you tell me what's your concern?
Yes, doctor. I am concerned about these symptoms of headache and sweating. What could be the cause, doctor?
Actually, Mr. Hassan, from listening to your history, I want to examine you. We have
Can you listen to me?
potential. Yes, we have differential diagnosis for this, but most likely you have growth in your kidney, over your kidney, and this growth releasing some proteins, which called epinephrine and norepinephrine. This coming in paroxysmus, and at this time they making your headache and sweating, and also increasing in your blood pressure, which is not controlled by medication. Also, we have family history of your father died because this growth or cancer in the kidney. It is related also to this condition. So we need to make some blood tests and do some imaging to confirm diagnosis and exclude other causes, Mr. Hassan. You have any other concern?
Yes, doctor. This condition is related to my father's condition?
Most likely, Mr. Hassan, but we need, as I tell you, to take a blood sample and do some imaging to confirm this.
So I may die at young age like my father, doctor?
Mr. Hassan, our role here to save your life and to give you the best treatment and best medicine. So we need to first of all to diagnose your case and exclude other causes, and after that we will give you the best treatment. If it is the case like your father, what's called pheochromocytoma, we can treat it early by making surgery and giving some medication to control your blood pressure. And the risk of this at this time will be low.
Yes, doctor.
You have another concern?
No, thank you, doctor.
Thank you. Mr. Ahmed, let me summarize what we have discussed today.
40 minutes.
You are certified here.
20 seconds. Time finished already. It's better, Dr. Yasser, to do the summary of the positive data before asking the concern. This is for me, actually. And that's what we are used to, the exam.
Yes.
Because there is no rule to give summary about and discussion of the concern again, give summary of the concern after finishing the station. So just to give positive data, summary of positive data after finishing the scenario, or finishing the history, give brief or summary of positive data of the patient and ask the patient if he has any other something to add to him or he didn't ask about. So what's your diagnosis and differential diagnosis?
My diagnosis for this, yes. My diagnosis for this patient, most likely patient has pheochromocytoma. We need to exclude thyrotoxicosis. We need also to exclude other drugs like amphetamine, like cocaine, also in this young age. Also chronic infection like TB, like HIV, also need to be excluded. Things like this.
Did you ask about any recreational drugs the patient is receiving?
I missed this spot.
So amphetamine can be one of the differential diagnoses.
Yes, and cocaine also.
Okay. Do you think the pheochromocytoma is included in other syndromes in this patient?
Actually, we need to ask about primary hyperparathyroidism, but patient has no abdominal pain, has no urinary symptoms, also medullary cell carcinoma.
Yeah.
Patient didn't ask about any neck swelling.
Okay. Any other syndromes? Maybe the cause?
Yeah, there is von Hippel-Leyden syndrome also, coming with pheochromocytoma with cyst also in the brain and cyst in the kidney, with polycystic kidney disease also. And patient may be die from cerebral.
Yes.
And the patient has cerebellar symptoms in this case, like ataxia.
Okay. So in Hebel-Lendo syndrome, it involves pheochromocytoma, renal cell carcinoma, and optic glioma or cerebellar angioblastoma. Do you think you asked about all the CNS symptoms
Yes.
for this patient?
Excellent. Ask about all CNS symptoms, about weakness, abnormal sensation, difficult speech, but I didn't ask about ataxia.
Okay. So you have any other?
I asked about visual symptoms. For this patient, differential diagnosis, cytotoxicosis need to be excluded. Also, drug, as we mentioned before, and chronic infection like HIV and TB also. But patient has no symptoms of this, and there is no risk factor for this. I didn't ask about active TB patient, but patient has no respiratory symptoms at all.
Okay.
Yes.
Yes, Dr. Omar.
I don't think a chronic infection can present in this manner, but I think an anxiety and panic attack will be one of the differential diagnoses. Also, hyperthyroidism, as mentioned and excluded by Dr. Yasser. Also, as you mentioned, cocaine and amphetamine, recreational drugs. Also, carcinoid syndrome can present in this manner.
Yeah, but you know, carcinoid is a triad of flushing and wheezy chest and diarrhea. So I think.
Yes, excluded from the history.
Mm-hmm. What about acromegaly? Can we put it as one of the differential diagnoses?
Yes.
With headache, sweating, and high blood pressure.
Acromegaly, yes, acromegaly needs to be excluded, but less likely.
Yes, but we have to ask about the symptoms of acromegaly.
Yeah, but not coming in paroxysm acromegaly. It's persistent headache and persistent sweating if the active, if it is active.
Okay. Also, hypoglycemia is one of the differential diagnoses. So we have to ask about hypoglycemia. So we have to ask about any low blood sugar measured during these attacks. Okay. So open discussion about the history. Well done, Dr. Yasser.
Thank you.
Anything in the history may be missed from Dr. Yasser?
Symptoms of hypercalcemia.
I agree with you, Dr. Omar. Symptoms of hypercalcemia of
min 2B و A.
This is min 2A mainly actually.
And the B.
But ask about tummy pain and alcohol habits. And also psychiatric manifestation about the mood.
Yes. But hyperparathyroidism. Hyperparathyroidism symptoms in the form.
Yes, Dr. Yasser, history of stone and tummy pain and neck swelling as well.
So pheochromocytoma can be involved in min 2A and min 2B. Min 2A involving thyroid medullary carcinoma and hyperparathyroidism and the pheochromocytoma. But min 2B, I think, involving marfanoid fissure and mucosal neuroma and hyperparathyroidism and medullary carcinoma. So min 2B is not involving pheochromocytoma actually. Min 2A is involving pheochromocytoma.
No, men 2 both.
And the B فندم بقى.
Men 2 both. Yes, men 2 both. Medullary carcinoma and pheochromocytoma plus for من 2A hyperparathyroidism for B methanoid restriction neuron.
Yeah. Yeah, but meant to be including also morphinoid fissures, I think, morphinoid fissures and mucosal neuroma.
Yes, Dr. Salim, meant to be
but no
like
hyperparathyroidism.
meant to A plus morphinoid features.
Yeah. Okay. So, Dr. Yasser, what you are going to do for this patient?
I will do for this patient basic investigation in the form of CBC, renal function test, liver function test. I will make also blood glucose. I will make 24 hours urine collection for epinephrine or epinephrine. Also, I will make road fast. I will also search for drug for amine and cocaine. I will make chest X-ray, cardiomegaly, which is hypertension, ECG also for any LVH, any abnormalities in the ECG. I will make echo for the patient also to assess the affection of the hypertension on the heart or exclude any other cardiac causes because the patient has a family history of premature sudden death.
Okay, what about investigation?
And also for men type, type A, I will do a parathyroid level. I will do serum calcium. I will do also for medullary cell carcinoma ultrasound.
Yes, what do you think?
Genetic testing can be done also.
Any investigation for pheochromocytoma?
24 hours urine collection for epinephrine or epinephrine, ultrasound of the abdomen, CT also can be done if there is any mass lesion.
And the serum plasma epinephrine?
Yes, serum epinephrine or epinephrine.
So you have to book the serum 24-hour urinary catecholamines and the epinephrines in the first of your differential, not in the last, because you choose the pheochromocytoma as your first differential diagnosis. So you have to book this investigation the first of your list of investigation.
I mentioned in the first.
Dr. Mubashir, also neurofibromatosis type 1 and 2. Yes, pheochromocytoma can be included in neurofibromatosis, but he asked about skin rash actually, and it was excluded, so that I think neurofibromatosis type 1 and 2 are excluded already by the absence of skin rash.
Yes, Dr. Sadiq, also there is test for pheochromocytoma that originates outside the adrenal gland.
Originate from?
From outside the adrenal gland.
Like what, Dr. Omar?
Meta-iado-benzyl guanine.
This is what?
MIBG. This is taken by tissue out that secrete epinephrine outside the adrenal gland.
Mm-hmm. Okay.
Okay.
So this case came in Egypt last night, or they died before? The night before. A case of pheochromocytoma, and it was involved in von Hippel-Lindau syndrome.
Dr. Sadiq, if the patient is female,
Yes.
what other differential?
A female patient?
If female also preeclampsia and early menopause can be a differential diagnosis.
Mm-hmm.
As you mentioned in the past, there is history patient, a 30-year-old lady presented with sign of menopause, and all candidates suggested it is pheochromocytoma and did not ask about gynecological history. and she had a history of hysterectomy.
Yes. So what was the diagnosis of Omar at that time?
At that time, diagnosed menopause, early menopause, because the lady had a history of hysterectomy, and she presented with symptoms of flushing, mild hypertension, and sweating.
But hypertension
changes.
is one of the symptoms of menopause symptoms?
No, the presentation like pheochromocytoma, flushing, sweating in this manner.
Yeah, but there is no tremors, no uncontrolled blood pressure.
Yes.
Whatever, if it's a female patient, we have to ask about all the menstrual cycle and last menstrual cycle and sexual activity, of course. In any station. Okay, Dr. Yasser, do you think this patient needs genetic testing?
Yes, to exclude, yeah, because this male type A is autosomal dominant.
Yes. And one Hebel-Lindau?
I think also autosomal dominant, but I'm not sure.
Okay, if the patient asked you about the percent of the, if his son is going to have the disease, doctor?
I will tell you this is him as hereditary disease, unfortunately, and it is autosomal dominant in some cases, in some with some syndromes. And at this time, there is 50% of children to be affected by the same disease.
So how much my child may have the disease, doctor? How much percent?
50%. 50%.
Okay. Okay, I want to aim for this team, so we have differential diagnosis form of hyperthyroidism.
Okay, doctor.
That. Okay, looks like can go. Yeah.
الو
Hello.
يا دكتور صادق يا دكتور صادق
تفضل يا دكتور سيد.
يا فندم
تفضل.
I think الفيرست differential diagnosis may be acromegaly دكتور صادق يعني دكتور ياسر forget maybe.
Yes, we told them to ask about symptoms of acromegaly in the form of the changing of the fissures and the changing the size of the rings and size of the shoes. Yes.
Yes. Hyperthyroidism also, I think he forget, and I think family history also for any hypertension or thyroidectomy or like that.
He asked about family history of similar condition or family history of any disease.
Type, what about migraine? Yes.
To fight for acromegaly, if it is active acromegaly, it will be persistent, not coming in recurrent attacks like pheochromocytoma. Also for cytotoxicosis, if not controlled with increased in thyroxine level, it will be persistent, not coming in recurrent attacks.
Yes, I will say in differential diagnosis, examiner, if ask you about what you, yes.
I think he did well in this situation. He asked about symptom of hyperthyroidism.
But if examiner asks about differential diagnosis, you will say the first differential diagnosis is pheochromocytoma?
Yes, I will make this.
Yes.
Yeah, actually, if you put hyperthyroidism or if you put any other differential diagnosis as a first, you will lose a lot of marks, so that you have to put your first differential diagnosis, which is the coming with the patient symptoms. So, pheochromocytoma, and this pheochromocytoma can be involved in von Hebel-Lindau syndrome, and they can be involved with the MIN type 2, and can be involved in neurofibromatosis type 1 and 2, hyperthyroidism, acromegaly, hypoglycemia,
migraine ممكن؟
No, why to include migraine, Dr. Faid? really not associated with
Because
no sweating.
headache become, headache come in attacks. And the whole head.
But you know, we are not checking, we are not discussing a case of headache only. You have to link all the symptoms together to have a good differential diagnosis. If we discuss as a case of headache, so that you have other list of differential diagnosis. So migraine is not including tremors, no sweating, no uncontrollable. Okay. Anyone want to add anything else to this station? Hello?
Dr. Sadiq? Dr. Zakir, for this case, reactor, hello?
أيوة دكتور زكريا اتفضل.
For this case, Dr. Yasser doing well for this case, but when he mentioned for the patient, your condition as your condition related to your father's condition. I think it is early to mention for the patient it's related to your father's condition, and you take this as usually surrogate in the exam. Usually big the mistake like this and speak again. Do you think I will die like my father by this condition?
So what do you think is the best answer, Dr. Zakaria?
I think the answer it is early to relate this condition to your father. I appreciate your concern about your father's condition, and we will do further investigation for the condition include or discover what the cause of your headache probably.
So the best answer is it may be related to your father's condition, but it's too early to confirm that, so that we have to do further blood test and imaging to confirm the diagnosis. And after that, we'll arrange another appointment to discuss with you the results and give you the definitive diagnosis, and they will refer you to a specialized doctor to give you the proper plan of management.
Yes, thank you.
Dr. Sadiq,
تفضل دكتور عمر.
for plan of management, we can tell the patient that you need treatment to control high blood pressure, special treatment, and the final treatment will be surgical removal, or it is early to tell him about this?
It is so early to tell him about surgical treatment. We give him only that the proper treatment will be given for him after definitive diagnosis will be reached.
Okay, fine.
But in the discussion, if the examiner asked you about the treatment of chromocytoma, you have to ask to reply him like that.
Okay.
Okay, next station, communication skills, Dr. Malik.
Okay, Dr. Sadiq.
You are senior house officer in the neurology clinic. You are about to meet Mrs. Hanan, who is 23 years old. She is coming to see you in the clinic today with her father, who has recently diagnosed to have Huntington's disease. There is no upfront family history. The doctor wants to speak to you privately about the possibilities of the genetic blood test to determine whether she is at risk of developing this disease in later life and possibly passing this condition to her future children. The case of genetic counseling.
start.
Okay.
Good morning, Mr. Hanan.
Good morning, doctor.
I'm Dr. Max, Senior Officer of Neurology Clinic. Nice to meet you.
Nice to meet you, doctor.
Ms. Hanan, I have been informed that you wish to talk to me about your father's condition regarding making some tests, whether you have risk for this disease or not. Am I right?
Yes, doctor.
Would you please tell me how much do you know about your father's disease?
Yes, doctor. My father has been diagnosed to have Huntington disease 1 month back.
I'm sorry for that. Have you been informed by the treating team about this disease?
Yes, doctor. Briefly, I was informed that this disease affecting the cognitive function of my father and abnormal behavior.
Okay. Would you please, you don't mind if I can explain more about this disease?
Yes, doctor.
Actually, as you said, this disease can affect the brain function, and it will start after the age of 30. And it's unfortunately a progressive disease and not curable. I'm sorry for that. And this disease inherited, which can affect 50% of the of the siblings if one is affected. And this can start with abnormal movement, which can deteriorate with time, and the patient will be handicapped with time. Also, behavior can be affected, and progressive affection of the behavior can lead to abnormal behavior, unexpected behavior, and with time can affect also memory and can cause dementia. Are you following me, Mrs. Hanan?
Yeah.
Okay. Would you please tell me what's causing you to make this test?
Yes, doctor. I knew that this is hereditary disease. It comes in families. So that I want to do the test to know if I have the disease or not.
Is there any pressure on you from you? Are you married, first of all?
No, doctor. But I have a girlfriend.
Are you married, Mrs. Hanan? No. Any pressure from anybody on you?
No, doctor. No voluntary. I came voluntary.
Okay, that's good. Actually, if you don't mind, I would like to do explain the test. The blood test will be taken from you, and at the same time, one sample should be taken from your father. And the test will compare your father's result with your result. This can take a few days. It will be done in regional specialized center. And as any other test, it can carry some disadvantage result. I mean, that this could be falsely positive, or sometimes even falsely negative. So there is no 100% guarantee that the test will be right 100%. Is that okay, Ms. Hannah?
Yes, doctor.
On the other hand, if the test is positive, it can make you depressed and affect your life, but at the same time, you can plan for your future babies by making some pre-implantation diagnosis test case if you planning for family. This is one of the advantage of this test. But also it could affect your job and your insurance license. How do you feel about that, Mr.?
I feel so bad, doctor. Hello?
Hello, are you hearing me?
Yes, doctor, I feel so bad, doctor. But actually, I want to ask, so if the test is positive, what does it mean, doctor?
If the test is positive, that means you are going to suffer from this disease. But no one can predict when and how this disease will start.
Yes. So, doctor, if the test is positive, sure, I have this disease.
We are not sure, but most probably, because I told you this test could be sometimes very a wrong positive result, false positive, or even wrong negative, false negative. We are not sure, and even if it's positive 100%, no one can predict when and how the disease will start, because different people can start different ages and in different ways. So it's unpredictable.
So, doctor, if you discover the disease early, you can give me proper management or something to cure the disease?
I'm sorry to tell you there is no cure for this disease, but at the same time, the research are going on, and no one can predict what can happen in the future regarding the new discovery in the science can find some treatment for such disease. We hope this can be solved with time.
What about the insurance?
But we can give some medication which can help improving mood, depression, or some abnormal movement. But just this treatment will not prevent the progression of this disease.
Yes. What about my insurance, doctor?
Actually, different insurance companies have different rules, but the majority of them can affect your insurance company license, your insurance license.
Yeah.
And the majority of them will not cover such disease. Do you have any other concern?
Yes, doctor. What about my child, doctor? He's going to have the disease?
Actually, it's early to answer this question because you didn't do the test yet, and it would be better not to do this test for them because they will make them depressed, and there is no benefit at this time to cure this disease. So it would be better to delay this until they are young people and they can decide whether they want or not. But at the same time, if you are positive, they carry the same percentage as you. 50% if you are positive, they will carry the same percentage. 50%.
Yes, doctor.
Do you have another concern, Mrs. Iman? Hanan, sorry.
No, it's okay, doctor. What? I have to do the test now, doctor?
No, I will refer you to the regional team for such test, and they will talk with you, and you can take your time, decide if you are going to do this test or not. You are not in a hurry to make this test now. You can cancel them, and after that you can decide if you are going to do this test or not.
Okay.
Okay, Mrs. Hanan, let us summarize back what we have discussed today.
your father has diagnosed Huntington chorea. You are going to make the test, and we have discussed what the cause of the disease or the manifestation of the disease, what the possible of result of the test, about the benefit and disadvantage of this test. And we are going to refer you to the regional team regarding who are making such test. Is that okay?
Yes, doctor. When this test is going to be released, doctor?
Actually, it could be released within 2 days. And you can arrange someone or announce someone who can get the result. And if you don't want anyone, you can yourself take this test. And this test cannot be informed by telephone. It should be by hand informed and given the result.
Yes, doctor.
Okay, I'll give you some pamphlet about Huntington's disease, about the test for Huntington's disease, what the benefit, what the disadvantage. If you have any query or concern, I will give you my contact number. You can call me. Is that okay?
Yes, doctor.
Okay. Who's taking care about your father?
Me and my mother, doctor.
Okay. Is there any difficulty taking care about him?
Yes, doctor, you know, because he's suffering from some behavioral changes and some mental changes, so that we are facing some troubles.
Okay. If you have any difficulty with this issue, we can arrange with social worker to help you regarding this difficulty.
Thank you, doctor.
You are welcome. بس في وقت.
بس في 2 minutes.
Okay. Does he smoke, your father?
No, doctor.
Alcohol?
No.
Any other illness? Blood pressure, blood sugar?
No.
What about the health of your brothers and sisters?
I have only one brother, but he's okay, doctor. He's an engineer and he's okay.
How old is he?
He's 50 years old.
Okay, that's good. What about the health of your mother?
She's okay, but she has diabetes, hypertension, but her health is okay.
Okay, that's good. Do you have any other concern?
No, thank you, doctor.
Thank you.
Okay, so what's the ethical and legal issues in this case?
This is counseling disease of patient who is lacking of competence, and the here to respect the patient autonomy, the daughter, and the justice to offer the test for all the people, and the beneficiaries to discover the test. If she is positive, she can plan her future baby, and the non-malfeasance to avoid any possible harm if she is positive and the baby could be positive. She can make early abortion or prevent of the pregnancy or abort of the pregnancy.
What about confidentiality?
Confidentiality of her father is lacking of the capacity. So in such situation, as she is the next of kin, she can sign for him to make the test from the father.
Yeah, she is the one who is going to do the test.
But she cannot do the test without comparing with her father's test. The test should be taken both. To compare with her father's test.
Her father is confirmed to have Huntington's disease already, and she's coming to do the test.
Yes,
Confidentiality.
there is a wide variety of this mutation. There is a wide variety of this mutation, and the mutation should be similar to that in her father's condition.
Yes. I mean that she has to be informed that the result will be confidential for her, and she is the only one to know about the result, and the result will not be released by letters or emails.
Yes, and she can announce somebody to get the result.
Yes. Okay, what about the consent?
When she is agreed, she has to sign the consent.
But you didn't inform me here about the consent.
Yes, I got it.
Okay. So that's all, Dr. Malik, only the confidentiality, and it concentrates on the confidentiality that this test is confidential for her, and the result is confidential for her, and she is the only one to know about the result, and the result not be allowed to be released by emails or letters. And also the consent, the written consent is very important if she agrees to do the test, that she has to write a consent for that. You forget also
And we have to refer her to the...
Yeah, to genetic center, regional genetic center, but she has to, you have to inform her it is informed consent. And also you forget to check understanding of the patient.
Yes.
That's all that you missed, but you did well regarding the explanation of the disease, and also explanation of the test, and the concerns she has regarding the test. But you have to inform her in the beginning of the session also about encourage her to make someone to attend with her husband or her partner. And you have to ask in the starting also the family history of similar condition and how many brothers, sisters, uncles, and aunts she has, and if there is any one of them is affected.
And what regarding her brother, is there need to tell him about making the test or no need?
Actually, she didn't ask, and her brother has to come and ask himself for that, and so that genetic counseling has to be done with him. Also, there is no hurry to do the test right now, and you can have time because the time doesn't matter.
Yes.
Okay, the ethical issue with this station is we have fixed ethical issue in all the stations. The autonomy, the patient had the right to know his condition and to share the plan of management. Number 2 is justice. Number 3 is beneficence and non-beneficence, to do good for the patient and not to do harm. Number 4 here is confidentiality. The patient himself has to know about the result of the test. No one else is allowed. And the consent, the patient has to write informed consent about the test.
Legal issue.
Okay, anyone want to add anything in this station? Okay, let us go to the next case with Dr. Dr. Omar.
Yes.
Okay.
What is station? I'm sorry.
Station 5.
Yes.
For the candidates who are attending for the first time today, Dr. Fayed, Station 5 is 8 minutes only, focus history and the examination and the concern in 8 minutes only. So you have to do analysis of the complaint and on the differential diagnosis, no need for systemic review, and the plus social history, medical history, family history, and the blood list. Then to do focus examination only for the patient. Then to ask about the concern. Okay, Dr. Omar, Mrs. Maha is 35 years old. She has been complaining of shortness of breath for the last 6 months. Please take focus history and proceed as appropriate.
Okay.
Okay, again, Mrs. Maha is 35 years old. She has been complaining of shortness of breath for the last 6 months.
Okay, let us start.
Okay.
Hello, Mrs. Nuha.
Hello, doctor.
Nice to meet you.
Nice to meet you.
I'm Dr. Abdulgadir from the medical department, and I have been asked to discuss with you your problem and to examine you. Is that okay?
Yes, doctor.
I got from the leaflet that you are complaining of shortness of breath from the last 6 months. Is that right?
Yes, doctor.
Would you like to tell me more about your problem?
Yes, doctor. I have shortness of breath for the last 6 months.
Yes. Is it started gradually or started suddenly?
Gradually, doctor.
Is it all over the time or there is episode?
No, all over the time, doctor.
Is it related to exercise or doing something?
It's more with exercise and exertion, doctor.
Okay. Right now, you can care at rest?
No, at rest it's okay, but you know.
Okay. Do you have any shortness of breath when you lie down?
No,
Have you ever get up from sleeping catching for breath?
no.
Do you have any cough?
Yes, doctor.
When did it started?
6 months back with the shortness of breath, doctor.
Okay. Is it all over the time?
No, it's going in on and off, doctor.
Is there any variation between day and night?
No,
Is it related to any trigger like cold weather or smoke or dust?
no,
Okay. Is it associated with phlegm?
no,
Any coughing up blood?
no,
Do you have any chest pain?
no,
Any wheeze?
no,
Any ankle swelling?
no,
Okay. Do you have any faint?
and you what?
Faint, attack of faint.
No,
Okay. What about your health in the past?
no history. I don't have history of any medical illness, doctor.
You don't have any asthma?
No,
Okay. Yeah. Mrs. Nuha,
yes, doctor.
do you have any lung or heart problem in the past?
No,
Do you smoke?
no,
Are you taking any regular medicine?
no,
Do you have any change in your weight?
yes, doctor. I lost 7 kilograms in the last 6 months.
Sorry about that. Is it intention?
No,
Okay. Do you have any fever?
no,
Do you have any contact with patient with a long-term cough?
no.
What is your job, Mrs. Nuha?
Yeah, I'm a teacher, doctor.
And do you drink alcohol?
No,
Mrs. Noha, do you have any history of clot in the past?
no.
Do you have any skin rash?
Yes, doctor.
Where is it exactly?
It is on my hands, doctor, on my body, and on my face also.
Okay, I'm sorry about that. Do you have any loss of hair?
No,
Uh, Is it rash related to sun?
no.
Any joint pain?
Yes, doctor. I have joint pain in my hands.
On both hand or one hand?
Both hands, doctor.
Where is the exact joint?
All joints, doctor.
Sorry about that. What about the nails?
No, no change in the nails.
Okay. What is about this rash? What is looks like?
It's linear, doctor.
Yes?
Linear. Linear hyperemic skin rash. Erythematous.
Okay. Mrs. Noha,
Yeah.
do you have any change in your bowel motion?
No, doctor.
Any problem with water work?
No.
May I examine you, Mrs. Noha?
Yes, doctor.
I want to examine the rash, typical rash, and to examine the both hand for joint.
Yeah.
Check
There is
the-
yeah. Both hand there is tightness of the skin. Tight,
Yes.
shiny skin. There is no swelling of the
Yes.
joints. No deformities.
Yes?
No muscle wasting.
Yes? What about the rash?
The rash is, looks like linear rash, erythematous.
Okay. What about the face? Any butterfly?
No butterfly rash. The nose is pinched with preauricular, puckering
Yes?
with shiny tight skin.
Yes, I want to examine blood pressure. I want to examine the chest.
Yeah, the
To
chest,
check
there is fine crepitation by basal bilateral.
what about chest expansion?
What?
Chest expansion.
Chest expansion, it's okay, normal. 2 minutes remaining.
Okay, I want to examine, to ask about blood pressure and to see medication chart.
It's okay.
Mrs. Nuha, do you have any problem with swallowing, Mrs. Nuha?
No, doctor.
Is it difficult for you to stand up from sitting position?
No.
Okay, Mrs. Nuha, do you have any concern?
Yes, doctor. I'm concerned about this. Shortness of breath, what it could be, doctor?
I think, Mrs. Nuha, from the history and examination I did, it most likely related to disease called systemic sclerosis. Do you have any idea about this disease?
No.
This disease is called tight skin. As from your examination, there is tight skin, and this disease is a problem in your lung, scarring in the lung. Maybe the most likely the cause, but we need to do some blood test and imaging to your chest to confirm and to know what the exact problem.
Yes, doctor.
For the time being, we are going to do some blood test and image to your chest to ascertain the cause and to know what is going in your chest. This is scarring or other problems. And we will ask the joint doctor of the joint, and to help, to give you more help.
Is it curable, doctor?
Unfortunately, this is not curable, but there are so many treatments, many ways for help.
Yes, time finished. Okay, so what's your diagnosis?
My diagnosis for this lady is systemic sclerosis.
What are you going to do for this patient?
I'm going to do for this patient general investigation, CBCSR, liver function and liver function test through life. I will do for her autoimmune profile. I will do for her chest X-ray and maybe CT scan to her chest. Also, I would like to check blood pressure and vital sign charts.
What autoimmune profile you are going to request for the patient?
Autoimmune profile, anti-scleroderma 70 and anti-centromere antibody for systemic sclerosis. Also anti-RMB for overlap syndrome.
Yeah.
Yes.
Do you think this patient has limited cutaneous systemic sclerosis or generalized cutaneous systemic sclerosis or diffuse cutaneous?
She has systemic sclerosis.
Which type?
It is not a CREST syndrome.
Is it diffuse cutaneous or limited cutaneous?
It is diffuse.
How did you know it is diffuse?
There is skin change in the face and in the hand, and there is
It can occur also on diffuse and limited cutaneous. Did you check the difference between the arm and the forearm of the patient?
no.
Okay. Okay, what's the treatment for the patient?
The treatment, there is a treatment for camouflage and cream for skin disease. And if she has high blood pressure, we'll give her ACE inhibitor and immunosuppressant for the disease in the form of methotrexate. And if she is pregnant or planned to get pregnant, we'll give her another immunosuppressant.
What about the general measures?
Yes, general measures, she needs education and physiotherapy and occupational therapy.
Yes. And the treatment of blood pressure?
Yes, with ACE inhibitor.
Yeah. What about if she has GIT symptoms?
If she had upper GIT symptoms in the form of GORD or dysphagia, which she can get benefit from proton pump inhibitors. And if she had diarrhea or malabsorption, she can get benefit from antibiotics.
Okay.
Yes, okay.
What about if she has secondary pulmonary hypertension?
Yes, if she had secondary pulmonary hypertension, she needs a cardiologist, but she can get benefit from vasodilator in the form of sildenafil, bosentan, or iloprost.
And diuretics?
Yes.
Okay, thank you, Dr. Omar.
Thank you, Dr. Saad.
Okay, let us to do open discussion. Anything in the history missed from Dr. Omar?
Okay, Dr. Sadiq.
تفضل يا دكتور رانيا.
If in station 5, when I go in and find a case of systemic sclerosis, should I go for differential diagnosis or direct my questions about systemic sclerosis?
Yes, I agree with you. I appreciate this question. I actually appreciate Dr. Omar because he didn't see the case. So if you saw the case in the exam, a case would be a clear case of systemic sclerosis, pinched tighty, shiny skin and pinched nose and puckering, so that you will go directly asking about the symptoms of systemic sclerosis. Regarding your question, there is some cases that you have to go directly into the symptoms of the disease, like ankylosing spondylitis, okay, like this case of systemic sclerosis, like also rheumatoid arthritis, but in rheumatoid arthritis, actually you have to ask about other differential of arthritis in the form of, neuropathic arthritis and reactive arthritis and arthritis. So you have to ask about this symptoms of the disease, then you have to proceed into the other symptoms of the disease. So in a case of systemic sclerosis, it is acute.
Thank you, Doctor.
So you have to ask about all the symptoms of systemic sclerosis, no need for other differential diagnosis. So Dr. Omar, he had difficulty in the beginning because he didn't see the case in front of him. So what we are going to do is to do analysis of the complaint, which is shortness of breath, the onset, course, duration, progression, worsening factor, and improving factor. Then to proceed into the systemic symptoms of systemic sclerosis. So for musculoskeletal symptoms, he has to ask about any skin changes, became more tired than before, shiny, any skin rash like telangiectasia and perbra, any joint pain and muscle pain. For respiratory, he has, of course, we asked about respiratory symptoms in the form of shortness of breath, including the shortness of breath, analysis of the shortness of breath. Also, you have to exclude any paroxysmal nocturnal dyspnea and any orthopnea. CVS cause symptoms in the form of difficulty of breathing, with rest, with exertion, awakening from sleeping, chest pain, racing of heartbeat, leg swelling for myocardial fibrosis, pericarditis, and secondary pulmonary hypertension. Rhinus phenomena, very important, which Dr. Omar missed in this patient. Any finger color changes when exposed to cold weather. GIT symptoms in the form of tummy pain, heart pain, feeling of or getting sick, difficult of swallowing. Is it more to fluids or solids? Do you feel the food particles getting stuck in your food pipes? And where exactly in your food pipes? Any loose motions or less motions for bacterial overgrowth? And for renal also, any kidney problem, any frothy urine, any history of high blood pressure. For renal crisis, do you measure your blood pressure before? And he has to ask about from other mixed connective tissue disease, for rheumatoid arthritis, for example, any joint pain, cough, shortness of breath, which is asked before, so no need to ask again. Any following of ear, mouth, sores, facial rash, for SLE, any difficulty of combing your hair or getting up from a chair for proximal mobility in dermatomyositis, any dry mouth or gritty eye sensation for Joplin syndrome. Then social history, the job of the patient and how much the symptoms affect his job and usual daily activities, with whom the patient is living with, smoking and alcohol history, medical history, family history, and the drug list. And in the examination, actually, you have to start with the complaint. The complaint is shortness of breath, so you have to auscultate the chest and auscultate the bibasal lung fills, actually, because lung fibrosis in systemic sclerosis is basal lung fibrosis.
No need to examine the chest fully. Only the back of the chest.
This is focused examination only, so that you have to show the examiner that you're examining the bibasal lung fills for bibasal lung crepitation, for lung fibrosis and heart failure. And you can examine the heart also, the heart by secondary pulmonary hypertension, for parasternal heave, pulmonary component of the second heart sound, GVP, lower limb swelling. Then you have to examine the hand for any joint swelling and any skin changes, any deformities.
Okay, thank you.
And the hand you can examine by look, feel, and move. Look for hand inspection, for deformity, scars, pigmentation, ulcers, for atrophies, for rhinos. Feel for joint palpation, for warmness and soreness. Move and move for functional status of the hand by prayer sign, reverse prayer sign, and picking up coins. And you can examine also for proximal myopathy, for dermatomyositis or steroid therapy the patient may be on. You can examine also the oral cavity for any mouth sores if you are suspecting overlapping SLE. Okay, so in a case of rheumatoid arthritis, a case of SLE, a case of systemic sclerosis, you have to ask about other mixed connective tissue disease. Okay, okay, what you are going to do for this patient, basic investigation in the form of CBC, lice, kidney function, liver function, USR, C protein, and the specific investigation in the form of autoimmune profile, anti-SCL70, anti-centromere antibody, anti-RBN, ribonuclear antibody, and also imaging for the patient in the form of CT scan, high-resolution scan of the chest. The treatment will be in the form of, for any patient, actually, there is general measures and specific measures. General measures, patient education and counseling, occupational therapy, physiotherapy, specific treatment of the form of, number one, treatment of GIT symptoms. We'll give pantoprazole or DBI. We will give prokinetic drugs. We'll give antibiotics if there is bacterial overgrowth. For cardiovascular system, we can give diuretics for secondary pulmonary hypertension, and we can give, if there is secondary pulmonary hypertension, we can give prostacyclin or sildenafil, and for rhinus phenomena, we can do warming of the hands by wearing gloves. We can give calcium channel blockers. We can give ACE inhibitor. We can give prostacyclin also. Nitroglycerin. But as for the treatment of renal disease, we can give angiotensin converting enzyme inhibitor. Okay, next case.
What is the role of penicillamine?
Penicillamine for this patient, of course, we have to give steroid therapy. Steroid, of course, is very important, the treatment. Steroid therapy, and if there is no response, we can give steroid-sparing drugs.
Yes. Yes, sir.
Somebody is telling that penicillamine is high protein.
No, penicillamine is not used.
Steroid therapy is the treatment of a choice. If no response, steroid-sparing drugs. Of course, for replying of the concern, this is very important. Most probably you have a disease which is called the systemic lupus, systemic sclerosis, which is a multi-systemic disease involving your food pipes causing dysmotility and difficulty of swallowing, your small blood conduits of your finger causing narrowing, coldness, and the color changes, your lungs causing scarring and shortness of breath, and maybe your kidneys causing high blood pressure. So what we are going to do is to do for you further blood test and imaging to confirm our diagnosis, and we'll arrange another appointment to give you the definitive diagnosis. At that time, we can refer you to a multidisciplinary team involving rheumatologist, a physiotherapist, a social worker, to give you the proper plan of management. So Dr. Omar referral is very important to a multidisciplinary team in such a case. Is it curable, doctor? No, I'm sorry, it is not curable, but it can be controlled by giving the proper treatment and follow up as outpatient clinic. Okay, next case with Dr. أشرف.
دكتور صادق.
تفضل يا دكتور فايد.
في الاو اس تي يا فندم not mention steroid for systemic sclerosis management خالص.
What's mentioned there? Well, long time I didn't read systemic sclerosis.
لكن معروف السترويد من العلاج الثاني.
إيه؟
No rule in sclerosis steroid.
لا من الأدوات الرئيسية في العلاج، الرئيسية الاسترويد رئيسية في العلاج بتاع السيستم السكون.
يعني هو مقسمها زي ما الدكتور سابق قال جنرال وبعد كده رينولدز وجي اي تي ورينال وريسبيراتوري.
ممكن عشان اللانج فايبروزس يا دكتور فايد ستيرويد ثيرابي فور لانج فايبروزس.
هو يعني it mentioned interferon and dibenicylamine for lung fibrosis.
And steroid therapy has no role in this case.
لا ما كيف يعني السترويدز رئيسية في العلاج، رئيسية للتسويق الإنجليزي، رئيسية للمايوباثي.
Steroid therapy we have a rule according to the lavage, the bronchial lavage of the patient. Dr. Ashraf.
ايوه.
Where is your comment? Steroid therapy has role in systemic sclerosis.
البنسلامين الفيرست تريتمنت انتي فايبروتيك تريتمنت، هو الفيرست تريتمنت للسيستميك سكليروزس. مع البنسلامين بندي immunosuppressants، والimmunosuppressants طبعا بتبدا بالستيرويدز، وزي ما تفضلت الستيرويد موديفاينج ايجنتس زي الميثوتريكسيت والسايكلوسبورين والاندوكسان وكده. انما المين تريتمنت اساسا هو البنسلامين زي ما الزميل ذكر، انتي فايبروتيك تريتمنت، وبياتي بعد كده الانتي الاميونوسبريسنس. يعني
Prednisolone is given to lung fibrosis according to the lavage of the patient, the presence of lymphocytes. Dr. Malik?
Actually, I remember that the only disease where there is no need for connective tissue disease is systemic sclerosis. You will not give steroids.
Even with lung fibrosis?
هو الكلام ده ما مكتوب في الكتب، لكن مكتوب في كل الكتب العلمية اللي بياخد ستيرويد.
But not systemic sclerosis.
دكتور نادر جميل. دكتور نادر.
Different from.
السلام عليكم.
You just came for the exam fresh.
حضرتك
هي
جت اول يوم حضرتك. هي جت حضرتك اول يوم، وزي ما حضرتك ما قلت كده بالظبط، هي كانوا ماشيينها مره بالمونري هايبرتنشن ومره ثانيه بالمونري فايبروزس. كانت كيس حلوه زي ما حضرتك ما عملتها كده بالظبط. هو انا بالنسبه للموضوع ده حضرتك، هو الاو اس تي القديم كاتب ان هو دي بنسلامين زي ما الدكتور اشرف بالظبط ما قال. هو البوكت بس كاتب ان هي سايكلوفوسفامايد، وشالوا موضوع الانتي فايبروتيك الكلام ده. بس انا متخيل ان هي دي بنسلامين، يعني لو جت وما فيش حد كاتب سترويد في السيستميك سكليروز، ومش عارف ليه بصراحه، انا مش متخصص، مش عارف، مش هفتي.
I think according to the lavage, bronchial lavage of the patient, if there is lymphocytes, so that it would be steroid responding.
هي غالبا هتبقى كده حضرتك بالظبط.
Okay, whatever we can put insulamine at the treatment of lung fibrosis. Okay. Dr.
Bronchopulmonary lavage in case of idiopathic pulmonary fibrosis, not in case of systemic sclerosis. Systemic sclerosis, no role for steroid.
Okay. هم حطوا كمان في idiopathic pulmonary fibrosis gastric lavage to be done. If the patient has lymphocytes, he will be good responsive for steroid therapy.
Yes.
Okay, Dr. Ashraf.
معاك يا دكتور صادق.
You have a letter from the GP. Your role is registrar in internal medicine clinic. Dear doctor, thank you for seeing 55 years old lady with 4-week history of thirst and excessive urine. She also That's all. Second. Dr. Ashraf. Okay, so your case is Mrs. Amani?
Hello.
Dr. Ashraf, you hear me? Hello?
الصوت بيقطع شوية يا دكتور صادق. الو.
ايوه يا دكتور اشرف سامعني؟
سامعك بس الصوت بيقطع شوية.
Okay, so Mrs. Amani is 57 years old. She has been complaining of increased thirsty and the frequency of urination for the last 4 weeks.
She is 37 or 57?
57, 57. This is history
She's an old
shortage.
lady.
Yeah. Okay, for Dr. Rayo again, station 5. Mrs. Amani is 57 years old. She has been complaining of increased thirsty and the frequency of urination for the last 4 weeks. This is systemic sclerosis file I sent to you. Station 5 already. العفو يا دكتور نادر. دكتور أحمد سلم عليك.
الله يسلمها ويسلمك.
نبدأ يا دكتور صادق.
Okay.
Good evening.
Good evening, doctor.
This is Miss Amani.
Good evening, doctor.
Yes, this is Dr. Ashraf, the internal medicine registrar for today. Can I have a chance to speak with you about your illness, Mrs. Amani?
Yes, doctor, please.
I received a letter actually speaking of excessive thirst sensation. Could you tell me more about that?
Yes, doctor, for the last 2 weeks I have increased frequency of drinking water and thirsty sensation and also going frequently to the bathroom.
Okay. Could you tell me it's by your estimate how much you drink per day?
Yes, doctor, I'm not sure, but it's as normal as before.
Yes. Could you tell me that if you drink just water or some other juice or some soda or some spirits?
Oh, doctor, water and some juices, maybe.
Did you feel that you are eager for drinking? Did you feel that you are thirsty and you want to drink, or you are drinking just without feeling of thirst?
No, I feel thirsty, doctor.
This thirst is started since 2 weeks.
Yes, doctor. 4 weeks, doctor.
4 weeks.
Yes.
And it's associated with some dizziness or syncope or blackouts.
No.
It's associated with feeling of difficulty in swallowing or painful swallowing.
No.
You don't feel your mouth is dry.
Yes, doctor, that's why I feel thirsty.
Yes, and during eating, it didn't bother you.
No.
Okay. And as regards the urine, you have a frequency of urine, but there is no burning during urination.
No.
Okay. Did you feel that you need to wake up during sleep to drink water?
Yes, doctor.
How many times?
Maybe one time or 2 times.
Okay. Did you feel that within the last 4 weeks, did you feel that you have any fever,
No.
loss of weight?
Yes, doctor.
How many kilograms you lost, Mrs. Amani?
Maybe 3 kilograms, though.
3 kilograms. Did you feel that you have your appetite is less than before?
No, it's okay, doctor.
It's okay. Okay. What about the medical advice? Did you have any medical advice about these symptoms before?
No, doctor.
You have never diagnosis of diabetes mellitus
No, doctor.
or hypertension?
No.
You don't have any past medical history?
No, doctor.
Okay. Could you tell me if you have received any medications over the last 1 month?
No, doctor.
Okay. I'm sorry for these personal questions. Could you tell me how about your regular or irregular periods? Did you have regular or irregular periods?
No, I don't have any periods anymore, doctor.
Since how long?
For the last 5 years, doctor.
Unusual time stopping the menses, or it was before the usual times within your family?
I didn't know, doctor, but I stopped menstrual cyclation, menstrual cycle, when I was 52 years old.
At what age? 45 years old?
52 years old.
52 years old. Did you do any operations before?
No.
Okay. Could you tell me, Mrs. Amani, I'm sorry, I will examine you while I'm speaking to you. It's okay for you?
This is station, this is not station 5.
This is not station 5?
You have to be taking, yeah.
Okay, I'm sorry for that, Mrs. Amani. Okay, let's continue our history. Could you tell me more about your symptoms as regards the thirst and frequent urination? You told me that you have stopped your menses since 5 years.
Yeah.
After that date, you don't feel any flushing attacks of your face or
No, doctor.
or any no back pains, no bone pains.
No.
Okay. How about your
Joint pain, doctor.
head? Did you have
Some joint pain.
what?
Joint pain.
Joint pain.
Yeah.
What specific joints you have pain?
My knees, my elbows, and my shoulders, doctor.
Your knees, elbows, and shoulders.
Yeah.
Both sides the same degree?
Yes, doctor.
Did you feel that you have a stiffness in the morning?
No.
And you don't have any associated rash with this joint pain?
No.
You don't have any urinary symptoms? I mean, the water works with this joint pain?
No.
Okay. Could you tell me about your head? If you have any headaches before?
Yeah, sometimes, doctor.
Sometimes. It's a
Yeah.
mild headache or severe?
You know, it is moderate headache, doctor.
It's what?
Moderate headache.
Moderate headache. Could you tell me if you have any symptoms in your eyes, in your eyesight?
No.
And you don't have any symptoms in your ears? I mean, ear aches or
No.
difficulty in hearing?
No.
Okay. What about your taste? You have any problems in taste sensation?
No.
In motor power, I mean weakness you have?
No.
You have any loss of sensations over your body?
No.
What about walking? Is this balanced walking or there is a problem in walking?
No, it's okay, doctor.
Okay. Could you tell me if you have, as regard any skin changes in the color,
No.
any redness of the eyes?
No.
Okay. What about the mouth? If you have any swelling around the mouth or in the neck,
No.
pain in the neck?
No.
Okay. No lumps and bumps and bumps in your neck or in your body?
No.
Okay. Could you tell me if you have any tummy pain?
No.
Okay. You don't have getting sick or feeling sick?
No.
You don't have altered bowel motion, I mean constipation?
No.
You don't have a change in the color of the back passage?
No.
Okay. What about the water works? If you have any, I mean, change in the color of the water works?
No, doctor.
Okay. And you don't have excessive froth in the urine, in the water works?
No.
Okay. Could you tell me, Mrs. Amani, if you have any problems as regards the I'm sorry for that, but I want to ask you, what's your job, Mrs. Amani?
I'm retired, doctor.
What?
I'm retired.
Yes. And you are married?
Yes, doctor.
You are living with whom?
With my husband, and I have one kid, doctor. He is now 30 years old.
And both are fine, doing
Yes.
well?
Yes, completely well, doctor.
Excellent. Did you have any disturbance in the mood recently?
Yes, doctor, because of this frequent urination and thirsty, I have mood.
Yes, I'm sorry for that. But before you start these symptoms, you don't have any social stress or life stress?
No.
Okay. Are you a smoker?
No.
You don't drink alcohol
No.
at all?
No, doctor.
Okay. So these symptoms have an impact in your daily life. That's correct.
Yes, doctor.
and it makes you most of time in the home for going to the bathroom. That's correct?
Yes, doctor.
Okay, I'm sorry for that. What about your father and mother? Any positive family history of similar symptoms?
2 minutes remaining. No, doctor.
Okay. Could you tell me about your chest? If you have cough,
Yes, doctor.
you have phlegm,
Yes, doctor.
what's the color of the phlegm?
It's dusty, doctor.
Since how long you start to cough?
You know, this cough for the last maybe 1 month, doctor.
Since 1 month.
Yes.
And it was associated with chest tightness,
Yes, sometimes I have chest pain, doctor.
fever.
No.
There is no any blood coming out in the phlegm.
No, doctor.
Okay. And this phlegm is rusty in color, as you said.
Yes,
What about the yes? What about the chest pain? Did you have chest pain?
1 minute remaining. Yes, doctor.
I'm sorry for that. Could you tell me more about the chest pain, if it's central or to the side of the chest?
It's the right side, doctor.
What?
On the right side of my chest.
It looks like needles.
No, doctor.
Yes. And what the character of pain you have?
Just dull pain, doctor.
Dull pain. Okay, I'm sorry for that, Mrs. Amani. Due to short running of the time, could you tell me what's your concern, Mrs. Amani, for the time being?
Yes, 40 minutes already.
Already?
Yeah. Okay, doctor. I'm concerned about this increased frequency of urination and thirsty. What could be the cause, doctor?
Actually, there is a lot of reasons for that, Mrs. Amani, and I'm sorry for the running of time, but I want to tell you that there is a...
The examiner won't be sorry at all.
I want to tell you that we have we should examine you, and we should do some lab investigations and some imaging. Because actually we have a lot of reasons. First of all, we should rule out the presence of diabetes mellitus, as it's the first reason that may be the reason for your symptoms. So we need to do a fasting and postprandial blood sugars. Number two, we need also to rule out the presence of diabetes insipidus. And this diabetes insipidus could be due to some cerebral lesions or some cranial lesions. And in that case, we need to do some imaging of the brain to check the intracranial structures, and also we need to do some urine test and the blood test to check for osmolality. This is the second diagnosis. The third list may be one of your electrolytes in your blood. One of your electrolytes could be maybe higher than normal, and this should be included in case that you have chest symptoms, because these chest symptoms may be related to one disease called sarcoidosis. Hello?
Yes, doctor.
It may be related to one disease called sarcoidosis, and this disease may be associated with elevated calcium level, and in this case also you will have the same symptoms. So this differential diagnosis of the three causes that I...
Yes, doctor.
Actually, we need also to rule out other minor reasons, but this is the major three reasons that we should exclude for the time being.
Okay. So, Dr. Ashraf, take care, the exam is not open time, huh? You have only for 10 minutes.
لا بس انا بحس ان انت بتيجي عليا شويه يا دكتور.
انت اللي بتيجي على نفسك يا دكتور. انت رايح تسال عن you are يعني asking for symptoms in the end of the station. يعني whatever, it's okay. So what's your diagnosis and your differential diagnosis?
يعني كل الناس انت بتديهم وقت كافي الحقيقه، انا بتيجي عندي.
والله احنا بنشغل الستوب واتش يعني مش بايدي.
الدكتور أشرف ما شاء الله هو جاهز، لكن شوية كده ببطئ شوية.
التايم فاكتور عنده مشكلة.
أيوة.
يعني we are going in this station, Dr. Ashraf, to correct my fault, our fault. If you have problem with the time factor, you have to take care. I think it's time.
وبعدين الحقيقه انا كنت فاكر في الاول انها ستيشن 5 ويعني كنت الحقيقه بجري بسرعه عشان خاطر examine the patient، ولكن في الاخر اكتشفت انها ستيشن 2 يعني.
وبعد كده نمت بقى.
فخدت راحتي بعد كده.
خدت راحتك قوي زيادة عن اللزوم يعني. It's okay. So what's your diagnosis and differential diagnosis, Dr.
As I said, there is three main differential diagnoses. The first one is diabetes mellitus.
Why
Second one
is the first one?
Because it's a very common disease, and this is the common presentation for diabetes at that age, over 50 years old.
Yes, did you ask about other diabetic symptoms?
I didn't ask except then you heard about. I didn't ask about any other symptoms of diabetes.
You asked about blurring of vision or visual disturbance, and the patient denied. Any frozen urine, the patient denied. You have to ask about any also pains and needles in the hands or the feet for as diabetic complication. The patient will deny. Okay. What else?
The second possibility is the other diabetes insipidus,
Yeah.
and in that case I must rule out the hypopituitarism that may cause the disease. And in this, نعم.
Why hypopituitarism? Did you ask about other symptoms of hypopituitarism?
I asked about dizziness. I asked about any skin pigmentation. I asked about the cessation of menstruation. I was suspecting that it may be amenorrhea, galactorrhea. I tried to find any pituitary pathology to have the addition of diabetes insipidus, but
Yeah,
I don't find
you didn't ask about hypothyroid symptoms and addition symptoms of hypopituitarism. You didn't ask about LH and FSH deficiency.
I asked about pigmentation and the dizziness.
Yeah, but you know, when you're asking about Addison, for example, you have to ask about all symptoms together, not a systemic review. The form of getting sick and feeling sick, postural hypotension or dizzy spells, when getting up from a chair, feeling sick or getting sick, hyperpigmentation, all together to show the examiner that you are asking about Addison itself. In hypothyroidism, you have to ask about confidence, weight gain, constipation, dry skin, you know, hoarse voice, low mood. To show the examiner also are asking about hypopituitarism symptoms. So you put DM as first differential, then hypopituitarism as second differential. Okay, what else?
Yes. The third one is the possibility of sarcoidosis with hypercalcemia.
Okay. With the presence of joint pain and shortness of breath. And cough.
And cough, yes.
So if we put the patient has cough, productive cough, and loss of weight, and the right-sided chest pain. So with polyuria and polytipsia, what's your put as first differential?
has sarcoidosis?
So sarcoidosis can be a cause, yes, one of the differential, but we have nephrogenic diabetes mellitus due to paraneoplastic syndrome. This patient may have lung cancer, okay, with hypercalcemia causing nephrogenic diabetes insipidus. CV also, yeah. So I put nephrogenic diabetes insipidus as the first differential.
يعني هو طبعا
I put the second differential is cranial diabetes insipidus because of metastasis maybe of the lung metastasis because the patient has headache also. I put sarcoidosis also as one of the differential diagnosis. So, Dr. Malik, when you went to the station, what did you put your differential diagnosis?
دكتور صادق أنا ما أنت
Dr. Osman, بس just to mute the mic, please. Okay, what?
Actually, I put both diabetes mellitus or diabetes insipidus, and according to the history finding, after that I will decide whether it's central, neurogenic or nephrogenic, and after that I will take history of any CNS disease, any surgery, trauma, radiation, any history of cough or metastasis, EB, mucosidosis, sarcoidosis. And then to the kidney regarding hypercalcemia or hypokalemia and hyperparathyroidism, as mentioned this history. And then for psychogenic, if he stop drinking, is improved or not. And to ask about Sjogren syndrome, very important because can cause dry mouth and at the same time happen with Sjogren renal tubular acidosis, can cause also polyuria and even stones. So it's very important to know from the start. It's dry mouth or feeling thirsty, because similar condition can actually mask the situation and surrogate can go, the candidate can go wrong way. Very important. Just the last thing regarding hypopituitarism not cause hyperpigmentation like Addison disease.
Yeah.
It will be creamy face, not hyperpigmentation.
To be better.
Yes, creamy.
Okay, so Dr. Ashraf, you bought your differential diagnosis as diabetes mellitus before going to the station, okay? So diabetes insipidus, cranial and nephrogenic, primary polydipsia, psychogenic polydipsia, okay? So,
Yes,
when you are talking about primary polydipsia, so you have to ask the patient, what about the amount of amount of the water you are taking? Is it like before or it is more than before? Okay, what about the amount of water coming out? Is it less than before or more than before, or the same as before? This is for primary polydipsia. For psychogenic polydipsia, you have to ask about the mood of the patient. If she has any bad mood, okay, recently, okay, because mood disturbance can be one of the cause of psychogenic polydipsia. Okay. Then we'll talk about central diabetes insipidus. In central diabetes insipidus, you have to ask about any history of head trauma, okay, any history of exposure to radiation. Then you have to ask about the symptoms of CNS symptoms, headache, clearing of vision or double vision, okay, abnormal sensation, blackouts, unsteady gait, muscle weakness, okay, getting sick or feeling sick. Then after that, you have to ask about paraneoplastic symptoms. Maybe the patient had, so most probably it breast cancer and chest and lung cancer, so that you have to ask about chest symptoms, very important, cough and coughing up blood, and shortness of breath, lumps and bumps, fever, okay, and loss of weight. This is very important. Then you have to ask about hypercalcemic symptoms for the patient for paraneoplastic syndrome. The patient has increased thirsty. What about constipation? Okay, and low mood and the headache. This is all symptoms of hypercalcemia. Then you have to ask about if you are thinking about hypocalcemia, to think about hypothyroid symptoms, and also ACTH deficiency symptom, nausea, vomiting, weight loss, and disease pills. And also have to ask about LH and FSH deficiency if female patient, about menstrual cycles, and about the loss of libido. So the drug list also is very important for the patient because maybe there is drug inducing nephrogenic diabetes insipidus like lithium or listate or democycline. Then you have to ask about any renal problem before. Then you have to ask about symptoms of diabetes mellitus and the complication of diabetes mellitus. So if you put good differential diagnosis from the beginning, you will proceed in a proper way into the case. So we have primary polydipsia, psychogenic polydipsia, cranial diabetes insipidus, which can be caused by post-traumatic, post-surgery radiotherapy, or brain tumor, pituitary adenoma, or even metastasis, or even vascular like pituitary apoplexy, or brain occupying lesion, or even sarcoidosis. Nephrogenic diabetes insipidus, which can be caused by some drugs like lithium and the orlistate, and the chronic renal impairment, and the electrolyte disturbance, hypokalemia or hypercalcemia, and hypercalcemia may be caused by paraneoplastic syndrome. The symptoms of diabetes mellitus. So Dr. Ashraf used a lot of time by asking about any ear pain, taste abnormality, any redness of eyes, and actually I don't think it has room in our case. It's just a wasting of time. So for this case, this patient you didn't do summary for the case, and summary will help you a lot for collection of positive data and will give you the proper differential diagnosis. This patient has loss of weight. This patient has cough for 1 month, which is productive. This patient has right-sided chest pain. This patient has headache. This patient has joint pain. Okay. So from these symptoms, I think paraneoplastic syndrome, so nephrogenic diabetes insipidus is my first differential diagnosis because of paraneoplastic syndrome and hypercalcemia. Sarcoidosis can be a cause also because the patient has joint pain also. It is not typical, there is no skin rash, but can be. The third will be cranial diabetes insipidus. The patient has headache, so it may be primary brain insult or brain specific lesion, pituitary adenoma, or secondary metastasis. So I'll not put the diabetes mellitus as my first differential diagnosis. Dr. Malik, what do you mean by MM? Osman, we are sorry, but just to mute the mic, huh? Because it makes it
okay, I will do it right now.
I'm sorry, man, but I tried to tell you, but the echo is disturbing us so much. Multiple myeloma, yes, it's multiple myeloma. for the case of hypercalcemia also.
Dr. Sadiq?
تفضل يا دكتور ياسر.
I think the key question in this case in the first investigation to ask about the amount of urine is equal to the amount of water drinking or fluid drinking. If like this, most likely the case is diabetes insipidus, like renal or nephrogenic from the start. Also the color of the urine, if the color of the urine like water, so I think it is better to ask about the amount of urine collected by day, how much nearly, and what is the color of the urine. If it is like water and about 10 liter like this, most likely patient has diabetes insipidus.
Yes, I think it's better to ask it like open question, Dr. Yasser. What about the amount of fluid you are taking? Is it like before or more than before? And what about the amount of urine? And how frequent you are going to the bathroom? And does it disturb you and wake you up from sleeping to go to bathroom?
Hello?
Yes, Dr. Amar.
Also, in nocturia, in patient with nephrogenic diabetes insipidus, he can wake up to pass urine every 1 to 2 hours. But if it is psychogenic, it's unlikely to go in this manner.
I agree with you. So, Dr. Ashraf, what you are going to do for the patient?
Actually, upon my scenario, I think about diabetes mellitus at first, because simply the common is common. So I should rule out.
I agree. Common is common, but we have symptoms, positive symptoms with the patient. So we will not give according to the common disease, but according to the positive data of the patient.
Dr. Sadiq?
Yes.
دكتور صادق I have comment يعني differential diagnosis احنا بنحطها قبل ما discuss الكيس.
Yes.
Okay. دكتور أشرف I think he do يعني he do differential diagnosis first is a common diabetes mellitus and then diabetes insipidus and then and the memory. يعني he ask about the common and then يعني if the patient negative يعني not have any symptom like that he will go to the next differential diagnosis. But I think you said about differential diagnosis after we discuss the case يعني I don't know يعني we put the differential diagnosis in the first when we discuss the case. Before we discuss the case we write 4 or 5 differential diagnosis okay to ask about one by one like that.
Yes.
Okay. I think Dr. Ashraf do like that. يعني he the first one is the diabetes mellitus. This yes is a common يعني common than nephrogenic diabetes mellitus insipidus like that.
Okay. So what explains the cough and the loss of weight and joint pain?
Yes, he asked already in the first.
Actually, Dr. Sadiq, there is no specific symptom in the scenario that you told us. If you recheck again all your answers, you will find there is no specific question or answer you gave it to me that clarify one diagnosis. If I spoke about the diabetes insipidus means that we have, as you said, there is manifestation of hypothyroidism or hypopituitarism, or there is history of trauma for the head, or history of previous radiation, surgical operation. Most of that I asked about and it was negative. All were negative. The hypercalcemia, there is nil symptoms for hypercalcemia. I asked about the mood changes before start of symptoms. There is no mood changes before start of symptoms. I asked about constipation, no constipation. Bone pains, no bone pains. يعني what I want to tell you that if you have a specific symptom in the scenario that give you a clue to one of this direction, you will go and make a different diagnosis. But there is non-specific symptoms. Loss of weight can happen with diabetes mellitus. 3 kilogram can happen with diabetes mellitus. Cough with phlegm, it's not the big deal. Cough with phlegm without hemoptysis means nothing. Cough with phlegm without hemoptysis does not mean that we have a cancer and paraneoplastic syndrome. Cough with phlegm, it can happen with anything. So I mean that when you have scenario without a specific symptom for a specific disease, so you will put a differential list upon the commonest common. So according to my thinking, I put diabetes mellitus at the start because it's very common at that age, and there is no I cannot find a specific illness other than it. Number 2 is diabetes insipidus, because actually diabetes insipidus can be even I will make diabetes insipidus after sarcoidosis. I will put sarcoidosis number 2 as it may collect the presence of joint pain with the chest symptoms. And number 3, it could be diabetes insipidus. This is my point of view.
Mm-hmm. Dr. Ashraf, when he is giving you positive data in the exam, he means that he wants to guide you something, okay? So the presence of chest pain, right side chest pain, and productive cough, loss of weight, of course it has to guide you something. And actually you didn't ask about diabetes mellitus symptoms, or systemic complication of diabetes mellitus. If this patient has diabetes mellitus or not. You didn't ask about peripheral neuropathy, for example. You didn't ask about tenopathy.
How come, Dr. Sadi? I asked about
Dr.
sensory
Sadi,
changes
clinical
all
signs
over
and
your
symptoms.
body. I asked about visual symptoms. I asked about
That's
CNS
very
symptoms. Huh?
You ask about, yes, I agree with you. Ask about blurring of vision, yes, or double vision. Did you ask about peripheral neuropathy?
Yes, I asked if there's any abnormal sensation you felt in your limbs.
And I deny it.
Any abnormal? Yes.
Okay.
It was negative.
Who's urine?
I asked also about urine color and urine frost and urine.
Yes, and I deny it.
Yes.
Okay, so we don't have positive data for diabetes mellitus except for polyuria and polydipsia. On the other hand, we have positive data, chest symptoms, okay, which is indicating maybe with loss of weight, chest pain, productive cough, which is indicating there is something in the chest of the patient. There is headache also, okay, which is indicated maybe there is something in the brain. So it is not a matter common is common. It's a matter of how the positive data or the positive symptoms of the patient. We can put differential diagnosis, but diabetes mellitus, but late in our list.
I think, Dr. Sadi, difficult from the history to differentiate diabetes insipidus from diabetes mellitus.
We are not giving definitive diagnosis, but we are giving superiority of the differential diagnosis. And Dr. Ashraf, the case has not to be typical. He will not bring a typical case for you in the exam. He will not give you lumps and bumps and loss of weight of more than 10 kilograms, and he will not give you coughing up blood. He's playing with you in the exam, to give differential diagnosis.
But you can give some abnormal or heavyweight symptoms. For example, hemoptysis. If you add blood tinged sputum, this will be very important. If you add, for example, turbidity, the urine was turbid, the urine was not clear, this will add for us something important. As regards the headache, if you headache severe, so I will analyze the headache more and more, and I know that there's a cerebral lesion. It's okay, but the symptoms that the patient gave it to me is he guiding me in the scenarios. That's what I want to say.
And in the exam, if you give you any symptom, positive symptom, you have to analyze and go away actually.
Yes.
But you asked about chest symptoms very late in the investigation, and it has to be asked earlier because of you have to consider paraneoplastic syndrome or sarcoidosis or histoplasmosis or EHT, which is causing paraneoplastic syndrome for the patient. Okay, so Dr. Ashma, what you are going to do for the patient?
We will take basic investigations as regards the complete blood count, kidney function test, liver function test. We will do also the sugar profile and lipid profile. Then we will ask for specific tests. We need to do a chest X-ray, and we need to check for the presence of lung swellings or hilar masses. We need also to do the urine osmolality, the morning fasting urine osmolality associated with serum osmolality. We need also to do a urinary sodium, spot urinary sodium, or 24-hour urinary collection for sodium excretion. We need also to do the, if it's available, we can do the urine deprivation test to investigate for the type of diabetes insipidus. We need to do a CT scan brain and pituitary fossa to check for any presence of any lesion in the pituitary gland. That's all.
Okay, how to differentiate between primary polydipsia and diabetes insipidus? By test investigation.
Actually, the water deprivation test started in the start. It will differentiate between the two main types, either the nephrogenic diabetes insipidus or neurogenic diabetes insipidus, and it will give us the clue for the primary polydipsia at the end. All of us knows that we do this water deprivation test over around 12 hours, and we are checking the urine osmolality and serum osmolality every 1 hour or 2 hours. And after some time, we give the patient the antidiuretic hormone as a drug, and we will check again the serum osmolality and urine osmolality after that for further 4 settings. If the improvement in the serum osmolality and the urine osmolality, this means that we have a neurogenic type. If there is no improvement and still the condition the same, we have either nephrogenic type or primary polydipsia. Usually we are failed to differentiate between 2 diagnoses by water deprivation test. Usually we are doing the salt load test to differentiate between the 2 other types, the nephrogenic and primary polydipsia.
Salt
loading test. There is one other test other than the water deprivation test. It's called salt loading test to differentiate between the nephrogenic and the primary polydipsia.
What about desmopressin acetate test?
What about what?
The desmopressin acetate test.
You mean the
UTFV?
You mean to give desmopressin?
Yes, to differentiate between cranial and nephrogenic diabetes insipidus.
This is the one step in water deprivation test.
It's done after water deprivation test. Water deprivation test to differentiate between primary polydipsia and diabetes insipidus. If the osmolality of urine osmolality is more than 600, this excludes water deprivation test. This excludes primary polydipsia. If it is more than 600, it means that there is diabetes insipidus. So we have to proceed into desmopressin test to differentiate between cranial and nephrogenic diabetes insipidus.
According to my knowledge, water deprivation test is formed of 2 steps. The first step is to check the gradual change in the serum osmolality and the urine osmolality with fasting of water over 8 hours. And then the remaining 4 hours, you will give desmopressin injection and check the result after giving it over another 4 hours. So it will be total 12 hours. And usually, to depend on cut-off point as regards 600, it's difficult to rule out both diagnoses. Even after giving the injection of desmopressin, there is also some similarity happened and some confusion happened between the nephrogenic diabetes insipidus and primary polydipsia. And in that condition, they need to do another higher specific test, which is the salt loading test. This is according to my knowledge.
Yeah. So actually, in the exam, he will not ask you about the details of the test and how the test is done. You know, but we have to know that water deprivation test is differentiating between primary polydipsia and diabetes insipidus, and that you know the test is done in 8 hours. Okay, I agree with you, and there is measurement of the basal weight and osmolality of the patient and urine osmolality, and then it is after that water restriction is done for the patient, and then the weight of the patient and the osmolality is measured every 2 hours. Okay. When to administer desmopressin for the patient if there is decreased reduction in the weight of 3% reduction of the weight and the plasma osmolality is greater than 300 at any stage of the test, or the urine osmolality is less than 600 at the end of the 8-hour period, so that we have to proceed at that time to desmopressin test. The cranial diabetes insipidus is confirmed when the urine osmolality increased to more than 600 after desmopressin administration. Okay, and the diabetes insipidus is diagnosed if the osmolality is less than 300 after administration of desmopressin, because it means that there is no response of desmopressin which is injected for the patient. Yeah, we don't want to do conflict for the candidate. Actually, it's
Yes, doctor.
yes, it is impossible to ask you about the details of the test. Just to mention the test and the exam, this is only.
Yes, Dr. Said, easy to interpret, but I think Dr. Ashraf, maybe he is not revising recently. I think the salt loading test will not use here. I think this for hyperaldosteronism.
Actually, it is not mentioned salt loading test here, Dr. Ashraf, in examination of diabetes insipidus. I didn't read about it.
Yes, this for diagnosis hyperaldosteronism.
No. If you give me some time, I will tell you the whole story. I want to tell you that the normal urine osmolality started from 100 up to 900. This is first of all. So the cutoff point of 600 or 300 are not specific and not accurate. This is the first point. The second point I want to tell you is steps that done in the test. You can give me just 1 minute. I will tell you the steps done in the test.
Okay, Dr. Ashraf.
Yes. I will review with you the steps of the water deprivation test. It will be a nice, a nice chance to review with us, all of us. The test, the concept of the test, that in normal people, if water deprivation happened, there will be intravascular depletion, and so the plasma osmolality increase, and so the urine osmolality will increase up to a limit. This is in normal people. In absence of antidiuretic hormone, the plasma osmolality will increase after water deprivation, but urine remain inappropriately low with continued diuresis. Okay, so in water deprivation test, we have two steps. The first step, we deprive water for some time and check the changes, and in the second step, we will give intramuscular desmopressin to correct the defect. And if we don't find the defect is corrected, so this means that we have nephrogenic diabetes insipidus or primary polydipsia. The contraindication for the test is confirmed thyroid and or adrenal insufficiency. So we need to ensure adequate hormone replacement of thyroid and adrenal before making the water deprivation test. The steps of the test, أولا, before the test, we are avoiding drinking excessive water over the night before the test. And we allow breakfast at the morning, and we are starting the test at 8 o'clock in the morning by wafting the patient with empty bladder, and we are calculate 97% of the amount of the body weight. It will be our basal level of the body weight. Second step, we will deprive the patient from water for 8 hours, and we will not allow smoking. No smoking will be allowed. Number 3, we will record all urine output every hour. Number 4, we will record the plasma and urine osmolality at 0 hour, 2 hour, 4 hour, 6 hour, and 8 hour. And we will do wafting of the patient at the same time. At ending of the test, which is after 8 hours, we will give 2 milligram desmopressin intramuscular, and we will continue collecting urine osmolality for more 4 hours. And we will allow the patient to eat and drink freely during this period, during the last 4 hours.
Dr. Ashraf, you are giving water deprivation test, then you proceed into desmopressin test. But when to proceed into desmopressin test? Which stage of water deprivation test?
Actually, the test, as I said to you, it's a complete test that include the last 4 hours of giving desmopressin. It's a standard test that will be done for all patients of suspected diabetes insipidus.
No. When you are doing the water deprivation test, we will proceed into desmopressin test under certain circumstances. If there is 3% reduction in the body weight and the plasma osmolality greater than 300 at any time of the test, or if there is urinary osmolality is less than 600 at the end of the 8 hours, at that time we can proceed into desmopressin test. You got my point?
Actually, according to my knowledge, the problem in the 600 that you said, 600 are not typical for diagnosing the disease. Otherwise, we will do it without any water deprivation test. We will depend on the urine osmolality as enough technique to diagnose the disease. But actually, this is not the truth. We are doing the test like that to have a final diagnosis at the end. So we will not depend on the urine osmolality that as a one result after 8 hours. We must go into the second step of giving desmopressin. This is what I read it before.